Hello, everyone, and welcome to March's AML Caregiver Chapter event brought to you by the HealthTree Community for AML program. My name is Katie Braswell, and I'm the HealthTree for AML Community Director. I'm very grateful to have each of you here for our meeting today and for your support in building this AML caregiver community. I'd like to let you know that today's session will be recorded, and the recording, along with the slides and any resources we discussed today, will be sent via email to all registrants within 48 hours after the event has concluded. I'm going to quickly walk you through some important Zoom features just in case you're new to using the Zoom platform. If you hover over the bottom of your Zoom screen, you will see a row of icons appear. To turn on your video, you will press the Start Video button and press it again in order to turn your video off. We would love for you all to keep your cameras on if you feel comfortable. Doing so helps to create a stronger sense of community. Each of your microphones should be muted and will be kept off by our team throughout most of the event. You may unmute yourself during the discussion time at the end. Press the chat icon to open up the chat box. If you have any questions or comments for us or for our speaker throughout her presentation, please type them here. And lastly, if you would like to verbally ask a question or make a comment during our discussion session, you will click on Reactions and then the Raise Hand option. We will review all of this again after Dr. Bryant's presentation. And now let's get started with today's event. First, I'd like to thank our sponsors, without whom this event would not be possible: Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. The topic of our event today is titled Supporting Your Loved One During and After AML Treatment. Here's the agenda for today. I will introduce our speaker, Dr. Ashley Lee Bryant, and she will spend the next 30 minutes giving us her presentation. After the presentation, we will open it up for your questions and comments and end the event with a few announcements. So let me take a second to introduce our speaker, Dr. Ashley Lee Bryant. Dr. Bryant is an associate professor for the School of Nursing at the University of North Carolina at Chapel Hill-Lineberger Comprehensive Cancer Center. Dr. Bryant possesses expertise with older adults in palliative and supportive care for patients with acute myeloid leukemia. Her research focuses on delivering multidisciplinary interventions to improve symptoms, functional status, and quality of life for both older adults with blood cancers and their caregivers. Dr. Bryant is currently the principal investigator for an NINR-funded feasibility and acceptability study, the Palliative and Collaborative Care Intervention, which is investigating a nurse-led and occupational and physical therapy-focused palliative and supportive care intervention for newly diagnosed with AML. We are so honored to have you here with us today, Dr. Bryant. Your work with AML patients and caregivers is clearly extensive, and in listening to you speak in other lectures, it's obviously what you're passionate about. We are so grateful for you to be here to share your knowledge with us today. And with that, I'll go ahead and let you get started.
Great. Thank you all for joining me today. It is a joy to be here. I'm sorry I have to be here under these circumstances where we have families and individuals with acute leukemia who are here, but I look forward to having a really open, honest discussion. We will definitely make sure we have enough time left for us to talk about your experiences. So we'll get started here. So supporting your loved one during and after treatment. As Katie says, I'm Ashley Lee Bryant from UNC Chapel Hill. And yes, UNC, we just beat Duke the other night. So woohoo, I had to just throw that in. It's the light blue, even though my earrings are a darker blue. And I just took on a new role there at the Cancer Center, really focused on research, training, and education for trainees and faculty members. So totally excited about this new role that I was just asked to be a part of. One thing I think is so important to always start all the talks with, in dedication and memory of those who will be diagnosed, who are on this journey, who have been in remission for years, those who are relapsed, those who are going through the stem cell transplant. I always think it's important to just acknowledge them and the work that they continue to give to really build this research infrastructure of how can we better understand how we can care for individuals with AML. And nobody fights alone. And as you know, with AML, it's the orange is the ribbon that we wear to signify that we are in support of those with leukemia. And nobody fights alone because it takes a team. And so truly the care partners or caregivers are the ones who are working very closely with individuals. So just wanted to acknowledge that we're all in this together. So the goal really of this next few minutes is really just to think about and identify areas for improvement in caring for your loved one during and after AML treatment. And then the second one is really this Q&A, but also gives us an opportunity to reflect on your experiences as a care partner. So I'll use the words care partner and caregiver interchangeably. I prefer the word care partner. I think when we think of partnerships, we think of working together. And so I do believe that care partners can really work with the individuals with AML to really help them better manage their illness. So this here is a slide from the American Cancer Society. I'm going to leave it up at least a couple minutes for you to figure out what state you're in and how many people have recently been diagnosed with some type of cancer. So this is the map of the United States of America. This is data from 2022. And the sad part of this is that there are going to be 1.9 million people diagnosed with cancer this year. And in North Carolina, this year, there's a projected 65,000 who will be diagnosed. And so this is always interesting for me to look at these over time to see that the number is increasing. And we know with COVID-19, there's going to really be focus on how many patients are getting their screenings and preventative care to ensure that they don't have cancer. So feel free to unmute and tell me which state you're in.
I'm in South Carolina, but my husband will be treated at Duke.
Okay, yeah, Duke. So you're right.
I watched the game the other night too.
Yes, yes. So South Carolina, you're right, not far from North Carolina, very close. In North Carolina, we have 3 NCI designated comprehensive cancer centers, Duke being one, UNC, and then now it's called Atrium Health Wake Forest Baptist is our 3rd NCI cancer center. So in South Carolina, 33,000 or so will be diagnosed.
Florida.
Florida? Wow,
Yes.
152,000. And so
Saw that.
yes, and there's various reasons for that. I mean, you know, Florida's huge. What are some other reasons you think people will be diagnosed with cancer in general in Florida? Why is the number high in Florida, California, Texas, New York?
I don't know if you're referring to the sun, different types of cancer. It could be skin cancer. I would think you're referring to that.
Yeah, I'm thinking of all cancers. So this here is all cancers. So we're going to talk
Florida,
about all
might there
cancers
be-
with this slide, and then we'll really delve into the AML component.
Might there be an elderly population in Florida?
Yes, people go there to retire, right? People are living much longer. It is the fastest growing population of older adults. And we know that people who are 85 and older, we know are the fastest growing population. Anyone else for their state?
I'm in Louisiana.
Louisiana. So LA, so 26,000. Yes, and you kind of can see, we say the Bible Belt here in this South area from, you know, Louisiana to Mississippi, you got Arkansas, Alabama, Georgia, South Carolina, North Carolina, Virginia. Yes, so there's lots of work that needs to be done in these areas. I just wanted to just share with you kind of the overview of cancers in general, and then we're going to narrow it down to AML. So this is available on the American Cancer Society site. It's free for anyone. They have all kind of facts and figures available related to different types of cancers, related to racial and ethnic disparities, And they even have PowerPoint slides that if you ever need to give a presentation, they already have those set. So another great resource for you. So AML, an aggressive blood cancer in which it is treated very acutely and emergently. And so oftentimes, as you all may know, you may have experience where you start maybe in the clinic or in the doctor's office or in the ED, labs are drawn, labs are abnormal. You really need to get to the hospital very, very quickly. And so there is need for urgent care. The median diagnosis of someone with acute myeloid leukemia is 68 years old. Probably for the past 10 to 15 years, it's been about 66, 67. So that number is increasing over time as we know people are aging and living healthier and longer lives. AML is a disease of males. So more than likely, you will see a higher rate of males, 60%, and females, maybe 40%. It's also more common in whites than blacks or other people of color. And there's a high risk for symptom burden and functional decline, depending on the type of treatment that you receive. This here is an image of a bone marrow aspiration and biopsy, and that is how nurse practitioners, physician's assistants, oncologists are able to determine a definitive diagnosis based on both the bone marrow aspiration and biopsy. And these happen more often than what many patients and their families would want. But this is a definitive way of knowing if someone's in remission or if they relapsed. It can be very painful as well. So oftentimes there is treatment that's given, such as like Ativan as a medication to help them relax, even pain medication to really prep them for this experience. Also want to think about clinical trials. Clinicaltrials.gov is another great opportunity for you to see what clinical trials are available. And those could be behavioral clinical trials like an exercise trial, or even some of the therapeutic drug trials. So I think it's important just for you to know what's available, right? And these include all kinds of clinical trials, just not cancer. So what are some of the common side effects in which patients and their care partners share about AML? One common is this myelosuppression, where they become very neutropenic, anemic, and thrombocytopenic. And I'll tell you more about what those big words mean. They have more likely to have fevers and infections, febrile neutropenia, bleeding, fatigue, and even infertility. So let's start with neutropenia. So those are really start to have early signs and symptoms of some type of infection. And those can really be infections, maybe in their urine, they're having a hard time urinating. It burns when they urinate. They have a lot of urinary retention. They may have a line, so a portacath or a PICC line or a Hickman, and you're starting to notice some redness around that area. That's where you start to think about what are some of the early signs and symptoms of infection. Also, adults come in with some breathing difficulties. So sometimes they may have pneumonia. So it's important to recognize some of those early signs and symptoms so we can get those treated as quickly as possible. It's important to know that when to call the office, but then when to go immediately to the emergency department to be seen. Neutropenic precautions really involve good hand washing, avoiding any sick family and friends, wearing the mask, making sure that your immunizations are up to date. And neutropenia, that's important because down here you'll see the white blood cells. You have normal cells and neutrophils. And so neutrophils are really the ones that come on board first to ensure that those are the fighter cells. And so we really want to make sure they come on board to help with any of that infection that may be happening. We also know with AML, there's a risk of bleeding. So safety is so important. So oftentimes we think of falls risk, right? So making sure there's no throw rugs, in the home. making sure they're wearing shoes as they're walking around, making sure they're not bumping their toe, picking at a scab, picking their nose and starts to nosebleed. We also think it's important too, in which some people don't like to discuss this, but sex is also something that's important to discuss because there may be bleeding. And so you really want to know what the platelet count is. And I think that's important as we think about intimacy and quality of life. And so we know fatigue is common in patients with AML. And we know their red blood cells are fairly low as well. But we really want to make sure that we keep a safe environment in all that we do, all kind of activities, and really decrease the risk of falls. Because if you fall and have a low platelet count, it can really be detrimental. And so oftentimes people who have fallen have hurt themselves badly. They fall and they may start have, a head bleed. So bleeding in the head, they may have bruising all over their body, and it's concerning. So safety is critically important. We say if fever is anything above 100.4 degrees or higher, and so that's Fahrenheit. And so if your loved one has a fever greater than that, it's important to call the office immediately and talk to the nurse navigator if you have one, to someone in the office, and then go straight to the emergency department. More than likely, you will be admitted into the hospital. They're going to do all kind of, your workup is what we call, where we would get blood cultures from you to determine where the infection is. The goal is to start antibiotics within 30 minutes to an hour after the cultures have been drawn. We're going to get a urine sample to ensure that you don't have a urinary tract infection. We're also going to get a chest x-ray to make sure there's nothing going on in your lungs in which there may be some pneumonia. And sometimes if there's a cough, there may even want to get a sputum sample. So we are trying to figure out, why is this fever above 100.4, and trying to really make sure that we can get a handle on it. Because we want to make sure that we can have the right antibiotics on board for you. And that's why recognizing early signs are very important. Another topic that's starting to have more discussion is really infertility. And, we used to say it was dependent on age, but we know oftentimes people are having children in their 50s and even 60s. And so it's important to know that most treatments for AML may cause some infertility. So it's important to have those discussions if you want to be able to have children. Have those discussions before you start the treatment. And that's important to have very early on. And I would say many places, I won't say most, but many places have someone who's an educator in this. They call it oncofertility. So oncology and fertility coming together to make sure that we can ensure that families, individuals can have that experience. And we know that leukemia drugs can harm a developing baby. So patients should use contraception. We even encourage that even when someone's neutropenic. So that means wearing a condom. That means females making sure that you're protected as well, because the concern would be if you become pregnant, there's harm to the child, particularly if you're still receiving treatment. So I know people don't like to talk about it. It's kind of one of those taboo things, but it's so important. And intimacy is also important. So I think it's something that I would encourage you to talk about with your loved one, and just bring it up and see how they've been managing this. Now I want to head into kind of the work that I've been doing at UNC. So I'm an oncology nurse. I've worked, as I said, at all 3 comprehensive cancer centers in North Carolina. And I just left the bedside at UNC as an oncology nurse in 2020 during COVID, but I transitioned into a new role at Transitions Life Care, which is Hospice of Wake County, as a hospice nurse. And so it allows me to really bring in all the different aspects of things that I really love about the quality of life model, and helping those during the end of their life. So I feel like I am right where I want to be. But the work that I do, I see individuals with AML and their care partners at least once a week. I do the recruiting of my studies with my research assistant. And this is our study, Palliative and Collaborative Care Intervention. And so one thing I want to just share with you is that this study has been ongoing since now, it's been over a year and some change. And we think it's so important to keep patients aware of what's happening. And so we sent this out in February of last year. And so just thanking people for participating in the study, letting them know we value their time and that they are making a difference. And I want you all to know you are making a difference in the work for us to be able to really have new treatments within these past 5 years. And then also during our study, we've had 3 patients who have passed, and we acknowledge that. So we send this to their loved one to let them know that we appreciate them participating, we value their time and effort. And then we've also reached out to those bereaved caregivers to really get a better understanding of what that experience has been like now that they no longer have their loved one. So we would interview them usually 3 months after the loss of their loved one, and they can share kind of when they started to see things, decrease in function, when they started to see this person not do so well, and then they're just so happy to be able to share and express all these things that they've had bottled up inside. So what is the PAC team? So the PAC team are registered nurses, physical therapists, occupational therapists, and even pharmacists. So pharmacists is what we recently included. We're all working together with older adults with AML. They have to be 60 years and older, have a caregiver who may be willing to participate in this. And our goal is to really start physical therapy, occupational therapy within the first few days of treatment. And our focus has been those who are receiving hypomethylating agents, such as azacitidine, decitabine, and then venetoclax, which is a pill. We know that treatment is moving from inpatient to outpatient setting. So there's going to be really a big push where care is going to be mostly in the clinic eventually one day. I really do see that. And then emergent care will be still the inpatient units, but really care is moving to more of your community cancer centers. And now they're even open on the weekends to make sure that your needs are being met. So we have a patient this week who we just recruited, met them. They completed baseline assessment surveys related to symptoms, their quality of life, their cognition. And now OT and PT saw them yesterday, occupational therapy and physical therapy. They're going to do a baseline assessment on them to kind of see where they are functionally, right? What's their gait? Are they at falls risks? What's concerning? Then the nurse takes the information that he or she has. OT and PT has that information, along with pharmacy, because pharmacy has a list of all the medications. We come together and talk about our findings together as a team, like a quick safety huddle, no more than 15 minutes. Then the goal is for us to be able to present to the patient and their care partner what we found from those assessments. And the goal is to co-create goals, SMART goals, in which that patient and care partner are able to work towards during these cycles of treatment. And when we say SMART goals, these are goals in which they're very specific, they are measurable, they are attainable goals, they are reasonable and realistic, and they're timely. And so these are goals related to fatigue management, for example, of how are you going to manage your fatigue. And so we all work together. We work with the patient and their care partner, and then we would call them each week to check in with them and have a coaching call. No more than 15 minutes a week, just checking in with you. How are things going? How are your SMART goals? What are you having some difficulties with? What's going well? We look forward to seeing you again, because with patients who are receiving HMA and venetoclax, they're there usually typically 7 days straight in the clinic, and then they go home for a few days, but they're back and forth into the clinic anyway. So really, we think it's important to engage them early on in the process at cycle 1, usually within those first 3 days of starting their treatment, to get physical therapy and occupational therapy involved. We know people are going to become deconditioned. That means their body's going to become weak. They're going to be tired, not just from the cancer, but maybe the other chronic conditions that they may have. So we think it's critically important. Let's engage PT, OT, and pharmacy early on. And that's what we consider as palliative. That's what we consider as symptom management, because we already know what the illness trajectory more than likely will be. And if we can really address it up front, they will have better quality of life. Some of the patients' experiences from our study have been rapidly changing symptoms. So I'll read these to you. They'll say the pain and the medications and getting to the hospital every 2 days or every 1 day, that's been difficult. You're right, because people are driving 2-3 hours to get to a visit. The couple that we just recruited, they drive 2 hours one way just to get to UNC. And they're coming back and forth each day. And there's a place they could stay, but they prefer to go back to their home and travel each day. Another patient says, and if you're talking about mobility after I've had treatment, it sucked for the first 2 go-rounds with the chemo that I had. I was very weak, very tired, and that all just took it out of me. And so that's a common symptom. So if you're working with your loved one, if you're a patient here, if you're a care partner, these are not uncommon things that you've heard of. And so I just want to normalize the feelings that you may be having related to these symptoms. You may feel good today or may feel good in this moment, but later on today, you may feel tired and may just need to rest. The other patient experiences is feeling restricted due to functional decline. Here's an example. I have a general tendency towards being weak. That is due to the fact that there's been a depletion of the red blood cells. Avoid the weariness, the tiredness, the weakness, the physical weakness that I have at the present time. So they feel very restricted, that they can't move around like they're used to doing. Or just to make life a little bit easier so that you don't get tired and winded as often or as quickly as you would want to. So these are two common themes that we're seeing from our patients. What about the care partners? What are they saying? Many of you may feel emotionally overwhelmed, or you may cry in private if something bad happens. You're not the one to say first, why me or why now? But after a while, you start to think about that. And you say, I'm only human. But no, the toll is there. It hurts me that he might not have the results that he wants. And this was from one of the care partners. Another one said, for the most part, I feel good. But when he gets a little depressed, I try to do funny things and help him out there because I know what it's like to be depressed. And this care partner had went through cancer herself. And so she knows what depression is. Another common one was this high burden for coordinating all of these different treatment schedules, because you still have to see the oncologist, the pharmacist, you still have labs, you have the infusion clinic, and it's an all-day event. And as one said, the biggest thing is his scheduling. It seems like based on the fact that we've got COVID, there's a lot of pit stops that we have to make. And I think the hardest part of this thing, if you boil it down, it's kind of like being on an airplane. I think this is a very important point here. Your actual flight time is only 5 hours, or maybe it's 20 hours of flight time to get to the other side of the world, but it takes you 40 because you're waiting in between everything. And many of you probably can relate to that. You're waiting in the clinic, you're waiting wherever it may be to get into the clinic or the hospital related to the COVID wait. You're waiting and waiting and waiting. Another care partner says, it's challenging the aspect of someone has to be available to take, someone has to be available to pick up. It was a balancing of really making sure that those arrangements are made, and then balancing your own life and your own work, and then try not to feel guilty for missing work and missing life, but then also not feeling guilty for not doing it. It's just a challenge. And so I remember this care partner here in particular, it was a sandwich generation. Her father, older adult, she's taking him back and forth, but she's still trying to work. So she has her computer there at the clinic visits. She's trying to balance everything with kids. So high burden is totally something that we do not prepare patients or their care partners for. As I close, and before we get into our Q&A, Some things I've learned about recruiting, which I think is important, and I would love to also hear from you if you've been recruited to studies and things that you found very helpful. One thing that my team and I have found is that the ideal time to recruit really depends on the setting. In the hospital, we would say it's best to do it either right before rounds or during rounds, so we could hear what the oncologists and the medical team are saying, or in the afternoons. In the clinic, we really say it's in between their appointments, that if we want patients to be a part of these research studies, we cannot have them come in extra. We have to do it in between these wait times that they have. And really look at their schedule to see they have 3 or 4 appointments today. We know they're going to wait a good hour. Is there something in which we can encourage them to do, engage in our survey, whatever it may be, so it can really help us better understand their experiences. Maximize the time in the clinic. It's important to have ongoing communication with the team members. So we meet twice a week, the physical therapist and occupational therapist. We meet every Tuesday and Friday morning for about 15 minutes. I think it's important to make sure that we share with the patient that their oncologists have referred them to the study, because I do believe people are more likely to consent when they know that their oncologist is in agreement with this work. And I think it's always important to be kind and compassionate no matter what. That means someone is dealing with a new diagnosis, relapse, remission, whatever it may be. And this is really something that's very difficult for them. And so I think it's important for us to think about how can we be empathetic, where we experience the feelings of someone else, or sympathetic, understanding the suffering that they may have. So as we know, there is a difference. Team acknowledgements, none of this would be possible without my team, but none would be possible without the patients and their care partners. And so I have a large team here. I do believe in interprofessional work. So that means working together to make sure that the patient's needs are being met. And here's my contact information. Feel free to reach out anytime. I would be more than happy to talk with you. OCN stands for Oncology Certified Nurse. And then I'm a fellow in the American Academy of Nursing. So if you're wondering what those credentials mean. Thank you for your time, and I look forward to some questions.
Thank you, Dr. Bryant. That was excellent. I know we all learned so much from your insights there. Something really powerful to me that you mentioned just right off the bat was potentially changing the language from caregiver to care partner. I guess I didn't really think too much about the difference prior to hearing you say that, but I think this is a really important shift to make, because you're right, it is a partnership, and caregiver kind of implies it's more one-sided. It's giving but not receiving back from the patient, and it is such a collaboration. So I think this is something that I'd love to take through the theme of our foundation and continue to utilize. So thank you for sharing that. It's so important. Let's see. So let's go ahead and get into our Q&A and discussion. I'm not seeing anything pop up here in the chat yet, but if you'd prefer to communicate that way, feel free. I have it open here. If anybody would like to unmute and maybe provide some questions or comments, you can raise your hand, or since we're a smaller group, you can go ahead and take yourself off mute. Let me just give everybody a second here to get their bearings and start to contribute.
I'm gonna step away for 30 seconds. Give me 1 second.
Absolutely.
Okay.
Okay, and I see Reba has come off mute. Reba, would you like to say something?
Sure. First of all, I'd like to, acknowledge or appreciate your work towards kind of the physical therapy, occupational therapy side of things. My husband was inpatient for the better part of 3 months, going through infusion and consolidation, and there was zero, PT involved. So when he came home, he was severely atrophied. But and we're awaiting stem cell transplant right now is where we are. And so I don't know if you have anything to share regarding nutrition, and if there is any kind of data or if there's any valuable resources, nutrition that specifically kind of fights cancer, that prevents cancer from coming back, from relapsing. Our oncologists, they pretty much just say, keep the weight on, and they don't really care, or they're not educated as such. So I'm wondering, what you can offer in that regard.
Yeah, thank you, Reba. And sit in positive energy that stem cell transplant will happen soon. Nutrition is critically important, right? I would say over time, there's been kind of this mixed approach to nutrition from the medical side of things. I will say it's nutrition plus treatment to really make sure that it's key. And I know some people are really focused just on the nutrition and they don't do treatment, and that's their choice, because I think we all have choices.
Yes, we've been watching Chris beat cancer.
Yes, that's right. That's right. I agree. So people always talk about ensures, protein shakes. In the hospital, we would make those little ice creams and put milk and really make it as, as calorie rich as possible. I think also sometimes patients may say, oh, I want something, a biscuit, let's say, or I want some French fries. And then they get it and they're like, oh, that smell's bothering me. Or they only eat one or two. And it's like, I went all the way across town, but it was just a thought of them having that, right? So I think we know their taste buds are going to change. So I think for nutrition, small meals every couple hours, keeping things around the house. And if they want to eat something that's greasy and unhealthy, that's okay, because I think the goal is we know that they're going to lose weight, with the treatment. And we really want to make sure that they have something that they enjoy. So when it comes to nutrition, I'm really big on getting the calories in, comfort food as well, because I do believe there's comfort related to eating. And then maybe even try to cook together or do something together. That also brings more of this intimacy. But I don't know, Reba, it's one of those ongoing pieces, but I think it's a great question.
I'm just trying to find some real, information to grab onto, because I'm not sure that macaroni and cheese, as comforting as it may be, is it actually helping his body, other than calories? I don't think so. So I'm trying to balance,
yes,
kind of going all in and crazy, right? And
yes,
turning orange from eating too many carrots, right? But
right.
So anyway, thank you.
Yes, sure thing. And the thing is, that I'm thinking of that mac and cheese, they may only even have a bite or two of it, right? They typically don't eat all of it. And if they do, they're going to get sick. So I also think it's important for those who may anticipate nausea and vomiting to really make sure that you time out those anti-nausea meds, especially ones that don't make them too drowsy. I do think there is value in that. Great question.
Yeah, I think those are all really great points. I'm a registered dietitian, Reba, and so I could talk about nutrition for hours and hours. I've worked in the inpatient and outpatient setting. So if you'd like to communicate more offline, that's definitely my cup of tea. I'd love to help out and maybe give you some suggestions, but you're right. It's so personalized and it really depends on the patient. Nutrition is better than no nutrition. So meeting needs is typically number one, but I think you're right in that there are some things you could do additionally that are more like antioxidant focused and more nutrient dense based foods. And so, yeah, we could definitely have that conversation. I'd love to say too that our chapter event in April, I have 2 Mayo Clinic dietitians coming to speak on nutrition. So definitely be on the lookout for that. I'd love to have you attend.
Great, thank you.
Okay, I see some things popping up in the chat here. And this is something, yeah, on my radar too. She's asking, do most cancer hospitals have care teams for patients like the team you have at your hospital? It would be great to know if like this integrative approach is happening usually, or is your situation unique, or is this something patients that are looking for this integrative approach have to advocate and ask for typically?
Yeah, great question. I would say that it's a little bit of all of that. I think your larger cancer centers definitely have more than one physical therapist and occupational therapist and pharmacists on their unit or in the clinic. But that is something you have to advocate for. I think no matter where you go, you're going to have to advocate for those additional ancillary and supportive services. So the team that we have at UNC, this has not been integrated in. So this is a research study. Our goal is to really take the results from that study and then show them at UNC from a financial perspective as well, the great outcomes of this, and then to be able to really put this in practice. And we use existing OTs and PTs. So these are existing staff members, existing nurses on the team who come together and really work. So it's not like we're outsourcing it where people are coming in, to do this research. I think, how do you really equip your existing staff? So the question is, do most cancer centers have care teams? They do. Typically, it's like a oncologist, a nurse practitioner, oncologist, and physician assistant. But when you start thinking about your comprehensive cancer services, most places have something, but it depends on the depth and breadth that they may have. So I think that's a great question to check into. And nurse navigators, case managers, all of them are also helpful. And the other piece too, I would just say with that, I think it's important to always ask for, if you need assistance with parking or food vouchers, whatever it may be. Sometimes people, when I say people, healthcare members don't always come out and say what those resources are. We kind of wait for you to say, okay, this person's in need. But if you can say, you know what, I need to talk to the social worker, very upfront. Let's talk about what's going on. I need to take FMLA. We need to do long-term disability. What's going on? These are my concerns. Let them know that up front, because then they could potentially get others involved to ensure that you have those resources.
Yeah, I think another important area of conversation along these lines is the early intervention, the importance of it being early. And that's what your study is looking at, right? Is it being like from the get-go, instead of there being some debilitation happening and then intervening at that point where you kind of like miss the boat a bit.
Yeah, and that's what usually happens when people bring OT and PT in. Someone's fallen, or they're getting ready to go home, but they've been in bed for the last 2 or 3 weeks. They haven't seen them get out of bed. And then you realize, wow, they really need home health services, right? They're so deconditioned, their body's so weak. Or they're fallen, and everyone's coming to their rescue. And the goal is, as you said, Katie, really and started early on. So I would say within that first few days, and they may say, well, they don't need PT and OT. Yes, they do. Everyone still needs it. It's nice to have an evaluation for someone to kind of see where you are and provide you some exercises or activities you can do while you're in your room, or when you sit in the recliner, or once you go home. Why do we have insurance, right? Why is OT and PT there, right? It's nursing can't do it all. The dietitians can't do it all. I just have to remind myself, care teams are there because you have specialty people there who are coming in based on their specialty area in their training to really make sure that we're meeting really the quality of life needs of that patient.
Yeah, absolutely. I have a question here from Kareth, who's asking if you could share how many people you currently have in your study.
Great question, Kareth. So we started this study January of 2020, and we had a control group. So they did not receive the intervention. We had 20 patients and 20 patients and 14 care partners. We make assumptions that everyone has a care partner, but they don't. And so now we've collected that data. Now we're focused on the intervention. We have recruited our second patient this week. I would say our first patient we recruited, she was in the hospital. She and her husband were excited about being a part of this study. And within 24 hours, she says, I'm overwhelmed. I can't do this. So we understood that. The second patient we just, or participant we just recruited, they are excited, they're ready. So our goal is to recruit 20 patients, and then ideally their care partner, and really follow them over time, up to 7 cycles.
I'm so excited to hear how this progresses, and as you continue to have findings, I just love to hear how it continues to go. I have a comment here from Todd asking about burnout, which we could do an entire session on for sure. But wondering if you have thoughts on how a care partner can keep mentally and physically well so they are able to best care for their partner.
Yes, I do think some way of not losing yourself in the role of being a care partner. So that means the routines that you're used to doing, you know, Todd. So I think it's important, if you're still hanging out with friends, still doing things together with people that you enjoy, and really thinking about having and being present at that moment, and whatever activity it may be, knowing that your loved one is going to be okay, right? Because there's certain things you have no control over, right? We have no control over it. So I think engaging in activities that really make you happy, and trying to get some walking in, remain as physically well as possible. I also think it's important to share with your loved one, maybe the stress. And this is hard. This is harder than I thought it would be. And I'm having a hard time, caring for you. And, I feel like we're fussing all the time. We're arguing. Things are just not going right. Let's talk about this. And so, at least once a day for an hour, I'm not going to be here. I'm going to be doing something else. But I think it's the communication. Oftentimes care partners hide a lot and they don't share with their loved one, which makes sense. And then you're holding all of that in, and then oftentimes you're about to blow like a huge volcano, because there's so much that's in you, but then you don't want to feel guilty or feel selfish to talk about yourself. So it is kind of this ongoing battle. I will say it's important, as we know with care partner burnout, stress, that you got to take good care of yourself. And so if you don't take care of yourself, you can't be able to take care of your loved one. And I do believe in therapy. I do believe in mental health services, talking to someone, releasing those emotions, feelings, whatever it may be. Someone who you trust, who you know is not going to judge you, but is going to let you get it out and allow you just to be you, and then provide you with the resources to be as successful as you can as a care partner. So Todd, I hope that answers some of that. I think it is hard to do that. There's not a one size fit model, but oftentimes people lose themselves. When I say their life, kind of like having a baby, everything is there, and then they grow up and it's like, well, what's going on? And so I think it's important to still maintain friendships and social engagement.
Yeah. And I think something that you brought up earlier with the incorporation of the SMART goals, whether that's from the patient or the care partner, that can be a great way to strive towards something and potentially instill joy depending on what the goal you're working towards is. And I was wondering if maybe you might be able to share an example of a SMART goal that you've helped set with a patient or a care partner, what that could look like for people maybe outside of the study who could start maybe following and doing some of that for themselves.
Sure, great question. One thing that we're starting to notice more of with older adults with AML, they may be hesitant to take pain medication, for example. I'm scared to become addicted to the medication, or I really don't want to take that oxycodone. So for example, we would help them rethink, reframe how they're thinking about this. And so let's say one of the goals is specific, because we know if we can manage their pain better, they can become more functional. And so I'm going to think of fatigue as a common one. So SMART goals, so specific. The goal is for us to better manage your fatigue, right? How can we measure that? We're going to do some different things throughout the day to ensure that you can do this in your breakfast time, lunchtime, and dinner time. Is it attainable? Is it actionable? It's kind of a yes or no. And how we're going to make sure that you can reach that goal. Is it realistic? Yes, it's realistic for us to do this 3 times during the day. I'm going to get up and walk to the mailbox, or get up and walk to the neighbor's house, let's say. And then is it timely? So that means, do we really need to, instead of 3 times during the day, maybe we just need to make it twice. Maybe you just need to cluster the care that I'm providing to ensure that I get what I need and I can manage my fatigue better. So it's really just thinking about, okay, how are we going to do this? I'm tired. I really don't want to get out of the recliner. I really don't want to get out of bed. I don't understand why you keep asking me to do this, Katie, why are you asking me to do this? Well, let's talk about this. And having goals. And I also believe in kind of some goodies or treats at the end. Like if we can get through this today, just imagine at the end, this is going to be our reward. So I do believe rewards really help as well.
Yeah, super helpful. I see one more question here from Todd, who's asking if this is an AML specific study or if it's open to other cancer patients.
Right now, it's just AML specific. The goal would be for us to expand this. Eventually we would love to expand this to the stem cell transplant units, burn hospitalized patients, older adults. But we think AML is really the ideal case example. So right now it's just AML, and particularly those who are receiving hypomethylating agents and venetoclax.
Yeah. Okay, well, I'm not seeing anything else in the chat. Maybe I'll give you a few seconds if anyone wants to come off mute.
I have one more question. It was along the same vein of what Todd had brought up, the mental aspect. And I know it's hard to probably incorporate all the aspects in your study, but is there a reason you left out the psychological aspect and not including like a social worker and I'm wondering, so my husband passed 4 years ago. And I remember social workers coming by, but they were not very often. And I feel like there's much more of a focus these days on mental health. I think that's increasing, but I'd love to hear if you feel like there's, those resources being made available to patients and care partners, in the cancer centers, because I don't necessarily think people are always going to go and seek them out, but I feel like if they're made available and they come by and try to talk to those people, and that they may take advantage of them in those instances.
Thank you for that, and my condolences of the 4 years.
Thank you.
Mental health is huge. I think we did not include social workers when we wrote this grant. This was like in 2018, and then COVID happened, and so it's been some time. I think the other piece is we didn't want to put too many different services like nutrition on for us to figure out what is the main component to really show some outcomes. We do believe physical therapy, occupational therapy, and nursing. Our goal is then to add more to the team, because I agree with you. Even PTSD is a big, concern in cancer patients. We always think of anxiety and depressive symptoms, but it's much more than that. We do have a comprehensive cancer support program that's available at the Cancer Center. So we have psychologists, psychiatric nurse practitioners, and others who are able to provide support, pet therapy, massage therapy. But that's the other piece. I think for someone to see a psychologist or psychiatrist with cancer, that has to be referred to by, their team. And, I think that's another piece of that, right? That should be early intervention, because we know that this psychologically, this is very difficult. So I think you bring up an excellent point. In the study, we do ask questions about, their psychological health. And during kind of our meetings with PTRN, so we're asking too about, anxiety. Do you have any fear? We're even asking about suicide, because we know that there's increased suicide in cancers in general. And so the goal would be then we would really tailor those SMART goals to what the nurse and PT and OT gets from that baseline data. And we would check in and we have it kind of a script that we would check in every week during our coaching sessions to ask about that. But I hear you loud and clear. I really admire and love our social workers, our case managers. I mean, they are the backbone of many of our programs, and they offer so much. But I agree, the plan is to include them. After this study, we'll see what was kind of the main ingredient that really showed the outcome. I think it's PT and OT. Others may think it's nursing. It could be a combination, and then we can start adding on additional services.
Thank you.
All right, I'll open it up. One last opportunity to come off mute, anybody, if you'd like to contribute before we wrap up. I'll share my screen in the meantime.
Feel free to ask any question. I mean, no one did say anything about the intimacy or infertility or sex, but I think that's one of those things people don't like to talk about, but it is important, very, very important. Sexual well-being is part of the quality of life model. And so I do believe having those discussions with your team and with your loved one is important. And rethinking what does intimacy look like for you.
Yeah. Okay, well, with 2 minutes left, I think we'll end right on the dot. So thank you so much, Dr. Bryant. This was so informative. We're so happy to have had you today, and maybe we can meet in the near future to discuss your official findings, and you'll have even more insight to share with us then. I'd like to mention that our next AML Caregiver chapter meeting will occur on April 20th at 3 p.m. Eastern. We're really excited to have HealthTree's financial coach, Diana Valentine, join us. Diana is a professional financial consultant and former caregiver to her husband, who was diagnosed with blood cancer. Through her professional and personal experiences, she is very well equipped to assist families affected by blood cancer in navigating all of the costs associated with care. So we're really excited to hear from her. You can find the registration page for this event and others by visiting healthtree.org/AML/community/events. And lastly, I have another really exciting announcement. We recently launched a brand new fitness tracking app called HealthTree Moves, where you can join challenges, track your activity, engage with others in the community, and even win prizes. We invite you to join us during April for our very first activity challenge through the HealthTree Moves app. We chose April to hold our very first challenge because April 21st is AML World Awareness Day. Our goal with the Active for AML Challenge is to start or continue healthy habits while building community and bringing awareness to AML. So the focus for this challenge is on being active where you are, wherever you are in your journey, while valuing the importance of sleep and hydration, all while realizing how small changes to your habits can make a difference each day. Activity for this challenge can come from anything that gets you moving through your day: walking, cycling, swimming, gardening, yoga, stretching, and strength training all count as minutes of activity. So the use of this app and the Active for AML challenge in April is open to all AML patients and caregivers. The challenge will start on April 1st, and we will have a collective goal of 200,000 minutes of activity for the month. So join in on the HealthTree Moves app by downloading it from Google Play or the Apple Store, and look for the icon I have here on the slide. You can also learn more at healthtree.org/moves. So I really hope to connect with each of you there. Once again, thank you to our HealthTree community for AML sponsors, Amgen, Bristol Myers Squibb, Genentech, AbbVie, and Jazz Pharmaceuticals. And thank you all for helping us to build a strong HealthTree community for AML. I appreciate you all for being here and hope you have a great rest of your day. I can't wait to see each of you again on April 20th and during our Active for AML challenge starting April 1st. Bye, everyone.